Hi everyone. Hi everyone, and very good evening to all of you. A warm welcome to all of you in this session in which we'll discuss a power-packed filled INICT main discussion points. And I also have shared the PDF of the same thing on our Telegram groups, including DBMCI Premier group as well as my own Telegram group. I feel that the audio and video is very clearly and fine. So I'll just talk about the session initially. This session is designed in a way that we can have quick revision of all the important topics that based on the last 5 years I feel has been asked and can be asked in the upcoming NICT exams. Uh, the best way to attend the session is to first look at the PDF in your own mobile phone and also simultaneously keep on listening to me. If you haven't downloaded the PDF, so please go to the DBMCI Telegram group and Premier group in fact, and also you can go to my own Telegram group and download the whole PDF from there as well. So first of all, a very warm welcome to all of you join this live. Hi Devashish, hi Solankar, Megha, and Hemant. Hi everyone. And to those who have joined it live, warm welcome to all of you. I'll just quickly revise the main important topics. I'll start with the topic of hemat. From that, I'll discuss the main topics of general pathology, and from that, I'll go to the topic of RBC anemia, and following that, we'll discuss the basic topics of systemic pathology. So I think you all are set up here. सर आप तो भी PDF दे दो मैं दे दिया हेमंत please look at the PDF, it's already available. So if you all are okay, please give me a thumbs up and can all start the session. So guys, if you all have got the PDF, please give me a thumbs up on the live group. So hi Sadiq, MS, Max Stuffins, good name, and Shreya, please give me a thumbs up and we can all start the session very quickly. This is just a 1.5 hour session. I'll try to remind all of those things in as quick possible. So this is not a complete revision. I'll try to revise as much as I can in the time frame given to me. So yes, I want a thumbs up from all of you. Fatafat, jaldi do. Chalo. Show some energy, guys, and all of you just give me a thumbs up and let's start the session quickly as soon as we can. Okay? So the high yielding pathology series is up here. This is basically designed for the INICT exams, and honestly speaking, you have come a long way and you should not stop. Especially this goes for those students who might have not been able to fare as much as they would want to in the NEET PG exam. So this is a very good opportunity for them to again show their mettle in the upcoming exams there. So चलो शुरू करते हैं. So कोई भी doubt होगा, you can just put me on the chat groups. I'm just looking at the chat live as well. I'll surely be able to answer you on the live period also. The first thing to discuss is this is a very probable question because this is WHO recent classification and was changed in W2022 and the previous one was 2018. The first important thing is AML with the defining genetic mutations. So previously it was AML with recurrent cytogenetic aberration, which has been changed to defining genetic mutations, and it talks about AML irrespective of the blast count. So basic genes are RUNX1, PML RARA, and CBFB MYH are the main mutation that is available and seen there. Remember, RUNX1, this mutation is often seen in AML M2. Okay, this mutation is often seen in AML M2. 1570 is seen in AML M3, and 1616 is seen in AML M4. One important point which can ask them, this was previously asked question though, that which of them will often be associated with the eosinophilia. Remember, among these all, the third one, CBFB MYH translocation of 1616 can show eosinophilia. So one more thing, this PML RARA has been asked as APML in the recent exams, so I'm very sure that this can be there. Now, gene mutation which can be also available, and these genes also have been included into the definition where something is AML irrespective of blast count. ठीक है ना? तो मतलब देखो कुछ ऐसे ट्यूमर्स होते हैं जो कि AML होते हैं without a blast count being 20%, and those important mutations are NPM, SEPA, NUP, MECOM, and FLT3. FLT3 is a multiple times asked question. They have asked you FLT3 has a poor prognosis. ठीक है, poor prognosis. So now देखो AML with myelodysplasia related, this is the second one. तो यहाँ पर we have to get either a history of MDS or a mutation of MDS which can be a chromosome 5 की deletion जो कि most common है, but can also be monosomy 5 and monosomy 7. तो ये जो question है ये probable question है because this was not actually before in the previous classification actually. AML थेरेपी रिलेटेड, अगर किसी पेशेंट को भी कोई हिस्ट्री है ट्रीटमेंट की, खासकर विद टोपो आइसोमरेज इनिबिटर और द अल्काइलेटिंग एजेंट्स, दे ऑल्सो हैव पुअर prognosis. देखो ये दिस इज अ वेरी न्यू थिंग दैट इज बीन एडेड. इट्स AML विद सेकेंडरी माइलॉइड न्यूप्लासम्स. अगर अ पेशेंट ऑफ CML is in blast crisis, it has gone to be classified as AML nowadays. The fifth one is AML with germline mutations. If a patient is multiple germline mutation है, जहाँ पर I think the most probable that can be asked to you is with that with Down syndrome, and Down syndrome is one AML with transient M7. तो अगर patient को Down syndrome है, they have a transient M7 and those patient have a good prognosis there. कोई डाउट है तो फटाफट पूछते रहो, ठीक है ना. सिद्धांत, फतेमा, नम्रता, जो लोग ज्वाइन किए हो मुझे, एंड या हाई मैक्सटफिन्स, अमर. तो जो भी आपको डाउट हो प्लीज़ कीप ऑन आस्किंग मी इन द रियल टाइम, आई विल श्योरली बी एबल टू आंसर यू, ठीक है ना. सो अब देखो ALAL इज अ प्रेवल क्वेश्चन बिकॉज दिस इज अ न्यू नेम नाउ. इट्स एक्यूट ल्यूकीमिया विद एम्बिगुअस लीनियज, जो कि दो तरह के होते हैं. इफ वन ब्लास्ट हैज टू स्पेसिफिक मार्कर्स इट इज कॉल्ड एज बाइफिनोटिपिक. अगर दो डिफरेंट ब्लास्ट है इन अ सेम पेशेंट इज कॉल्ड एज मिक्स फिनोटिपिक. But do remember, to call something as biphenotypic or mixed phenotypic, we should have a specific lineage markers. अगर किसी पेशेंट में specific lineage markers नहीं होगा, then we cannot call this ALAL. Okay, in that case we cannot call this ALAL. ठीक है, चलो. Now one thing that's as a very probable question now is a AML defined by differentiation. तो इसका पहले नाम होता था AML NOS, not otherwise specified. अब नाम चेंज हो चुका है टू डिफाइंड बाई डिफरेंशिएशन. कैसे याद करना है? M0 विदाउट डिफरेंशिएशन, M1 विद डिफरेंशिएशन, M2 विथ मैच्योरेशन, M3 प्रोमाइलोसिटिक है, M4 है माइलो मोनो, दोनों 2020 ब्लास्ट, M5 है मोनोब्लास्ट, M6 है एरिथ्रोब्लास्ट, M7 है मेगा कैरियोब्लास्टिक ल्यूकीमिया. Now in all these AML M0 to M7 we should understand that M0 without differentiation has the poorest prognosis, जबकि अगर कोई most mature है it has the best prognosis as referred to as a chloroma. ठीक है, अब इसमें देखो क्वेश्चन क्या क्या आ सकता है. Most common leukemia which shows a gum hyperplasia is actually M5 more than M4 gum hyperplasia के लिए, and also for same thing for skin involvement. अब डाउन सिंड्रोम जस्ट मैंने बताया इसके पहले, द डाउन सिंड्रोम इज ऑफन विद AML M7 एंड M6 M7 कैन ऑल्सो लीड टू दीज टू कैन ऑल्सो लीड टू बोन मैरो फाइब्रोसिस. ठीक है, अच्छा. नाउ अब एक रीसेंट अपडेट समझ लो. M3 जो नेम है acute promyeloid leukemia, so this name has been retained but this M3 word has been removed. Why? Because nowadays the APML is classified basically by the mutation. If you see a bifolded nuclei, as a folded nuclei with multiple OR rods, maximum OR rod in fact, the patient has high risk of DIC and will have high PT, high ability and dimer. But the point to understand in this location is, suppose a patient has a PML RARA, only then the ARTRA drug is effective. So rather than classifying something on morphology, the APML diagnosis is based on mutation analysis. इसीलिए M3 word has been removed. Okay, M3 word has been removed. And again, this was this year's NEET PG question also. याद है सबको? ARTRA, all trans retinoic acid, all trans retinoic acid, and you can also give arsenic trioxide. अच्छा, तो all of you have, I have one question for all of it in this live. फटाफट आंसर करो. As a treatment of AML ALL, in which of them will you give prednisolone? बताओ मुझे. All of you set me in the chat box. चलो, I move to the ALL classification of W2022. It is same as 2018. कोई चेंजेस नहीं है इसमें. देखो, प्रोग्नोसिस में फेवरेबल एंड अनफेवरेबल प्रोग्नोसिस है, जहाँ पर एज 2 to 9 years इज फेवरेबल, लेस देन 1 year, मोर देन 10 years इज अनफेवरेबल प्रोग्नोसिस. ठीक है, फीमेल्स फेवरेबल, मेल्स हैज अनफेवरेबल प्रोग्नोसिस. TLC में लेस देन 10,000 फेवरेबल, मोर देन 2 lakh अनफेवरेबल. फैब यूज नहीं होता आजकल, बट L1 हैज गुड प्रोग्नोसिस एंड L3 हैज अ पुअर प्रोग्नोसिस. WHO में इफ यू गेट ट्रांसलोकेशन ऑफ 1221 इट्स गुड, विथ हाइपर डिप्लॉइडी एंड ट्राइसोमी इज ऑल्सो गुड प्रोग्नोसिस. बट इफ अ पेशेंट हैज 514, 922 और एनी क्रोमोसोम विथ 11, they have a poor prognosis. ठीक है, this often referred as hypodiploidy is also a poor prognosis. If a patient में bone marrow response आता है within 7 days, it's good prognosis, and beyond 28 days have a poor prognosis. And yes, very well said, all of you, Anurag, Saurabh, Swati, Namrata and Bhavna, you all right. Prednisolone देते हैं in ALL. This was also asked in this year NEET PG. Okay, in this year NEET PG the question asked was prednisolone के साथ ट्रीटमेंट कौन सा होता है? It is actually ALL. चलो, next we move to the lymphoma topic. अब देखो लिम्फोमा में जो बेसिक कंसेप्ट ये कहता है कि व्हेनेवर अ बी लिम्फोब्लास्ट व्हिच हैज अ टीडीटी 34 19 20 व्हेन दे मैच्योर टू बिकम बी लिम्फोसाइट्स, तो बी लिम्फोसाइट में 1920 के साथ व्हाट यू गेट इज CD45. ओके, व्हेन दे गो टू नाइव बी सेल्स इट कम्स 5 पॉजिटिव, mantle also has 5 positive, GC area has 10 positive, post GC area has 23 positive. Now when they move to become hairy cells, memory B cells, and they become plasma cells have CD38 positive. Now the point is कौन सा lymphoma, which lymphoma arises from which area? So ध्यान रखना, naive B cell से CLL, mantle से mantle zone lymphoma, GC से follicular DLBCL Burkitt, and post GC से CLL. From the memory B cells, hairy cell leukemia comes out, and from plasma cells, it is multiple myeloma that comes out. So it helps us to remember all the CD markers. Example, marker for CLL 5 and 23, marker for mantle cell lymphoma CD5, marker for follicular DLBCL Burkitt CD10, marker for multiple myeloma 38, and marker for hairy cell leukemia, very different markers वो हम बात करेंगे in the lower bound table. इस टेबल को देखो. So what are the MCQs asked here? CLL or SLL, chromosome number 13q deletion. Okay, chromosome number 13q deletion. So chromosome 13q deletion, isme we get CLL, and this is having 5 positive and also 23 positive. Peripheral smear, it has a convent girl appearance and shows smudge cell. Smudge cell, to it's always asked in MCQ, and since they don't show true follicle, we use the word pseudo follicular architecture. ठीक है. Then comes the mantle zone lymphoma. How to remember? Single L, तो BCL1, chromosome 11, cyclin D1, and everything is 1 and 1. SOX 11 positive. They are 5 positive, and obviously mantle zone lymphoma will show you what? Mantle zone proliferation. In follicular lymphoma, double L है, so BCL2, chromosome number 18, and as a rule all lymphoma translocates with chromosome number 14. वो rule होता है. So what is here? 14, 18. Chromosome number 10, and it shows a true follicular pattern. Okay, true follicular pattern. Next is the diffuse large B cell lymphoma. DLBCL, it has a Epstein-Barr virus positive and HIV. This is a very important question. Is a most common lymphoma in India. You expect this question this year. ध्यान रखना. Okay. Now B cell 6 positive and has a diffuse effacement of lymph node and medium to large high lymphocytes. Burkitt में B, and B looks like number 8, and after B what is the gene? C. So C-MYC, which chromosome? 8. So anything with 8 like 2 8 822 or 814 will be Burkitt lymphoma. Two important questions जो कि इस बार भी पूछा गया था in this year's NEET PG. It shows a bone marrow aspiration where it shows typical vacuolation, we call them cytoplasmic vacuoles, and in the tumor biopsy it shows a starry sky appearance. ठीक है. In the marginal lymphoma it shows a BCL10 which is on chromosome 1, so obviously it will show you 114. But this question was asked in this May INICET, so I expect this question to be matched here. Chlamydia में ocular maltoma, in H. pylori gastric maltoma, Borrelia में skin maltoma. Sjogren's and Hashimoto will also cause maltoma, and such maltoma are which lymphoma? Marginal zone lymphoma. Okay, marginal zone lymphoma. Hairy cell leukemia will show BRAF, and it shows the chromosome 11C 25 103 and FMC7. So this all are important. जहाँ पर if a single marker is asked to you in the exam, the best marker is CD103. Okay, they show these typical stains: TRAP, annexin A1 and DBA44, and the typical biopsy pattern. You all remember this is a fried egg appearance. ठीक है. In plasma cell myeloma, they show a typical halo, and halo has a HOF. They can show you MOT cells, and they can show you flame cells. The inclusions can be intranuclear, we call them Dutcher bodies, and intracytoplasmic, we call them the Russell bodies. Okay, so all these lymphoma mentioned from this 1 to 8 is a B cell lymphoma, and all of them are often treated with R-CHOP therapy. R-CHOP. Okay, R-CHOP therapy. R-CHOP में R क्या है? Or if you tell me in that group what is R there? This is a question for you. Okay, and do you remember this was asked in this NEET PG that which of this treatment for multiple myeloma, which is bortezomib, was the answer there, will increase the herpes reactivation. So answer is bortezomib. Bortezomib causes a bit of immunosuppression and can lead to herpes zoster reactivation? This was question asked in this NEET PG. Chalo. So now we move to the Hodgkin's lymphoma. Okay, before I move, एक question है. So yes, Mega, देखो neuroblastoma में we don't see actually the c-MYC, we see n-MYC. तो MYC also is c-MYC, n-MYC, l-MYC. l-MYC होता है in lung cancer, c-MYC होता है Burkitt lymphoma और n-MYC होता है in neuroblastoma. Am I making it clear? Tell me in the group. Very good. Yes. So Nandita, Bhavna, Anurag, and Sangeeta, it's rituximab. R is rituximab, and rituximab is a CD20 antibody. It's also a immunomodulator. Now, Hodgkin lymphoma. This question is a very probable question because Hodgkin is hot favorite for the INICET people. Because the B cell in the GC area, because of Epstein-Barr virus positive and the NF-kappa beta, they transform to this type of binucleate owl-eye appearing cell. We call them Reed-Sternberg cells. So they don't have the B, T or NK marker positive. They in fact a special marker called as CD15 and 30 is positive in Hodgkin's lymphoma. How to differentiate them? Classical versus non-classical. Classical में देखो 15-30 positive होगा and same thing is negative in non-classical. However, non-classical has 20 positive and negative in classical Hodgkin lymphoma. EBV is positive in classical and negative in non-classical Hodgkin lymphoma. B cells, they can also, for that matter, NF-kappa beta and the marker of the B cell 6. Along with that, the marker, it is often positive and negative in the classical Hodgkin lymphoma. Same thing also in non-classical Hodgkin lymphoma. Okay? Achha. Now देखो these four important types of classical Hodgkin lymphoma बहुत easy है याद करना. Mixed variety, M for mixed variety, M for mononuclear RSL is the most common variety in India and also is the most common in HIV patients. In nodular sclerosis, sclerosis मतलब होता है hardening, and while a tissue gets hard, this whole area becomes cleared because of collagen, and hence it's seen in lacunar cell. Okay, lacunar cell. Lymphocyte rich and depleted is also seen in the classical variety. What MCQ I expect this year is on NLPHL. NLPHL, rather than P for predominant, P for popcorn cell, also called as LNH variety. This variety is the rarest variety and it has the best prognosis and has a Epstein-Barr virus negativity seen in the NLPHL variety. So I think I have made this very perfectly clear of all these Hodgkin lymphoma, and the treatment is A, B, V, D regimen. I know that you all know adriamycin, bleomycin. All of you tell me in the group what is V and D. That's a question for all of you. V and D in ABVD regimen. Chalo. This comes the first one, first part of the WBC basic important things. And now move to the next part of the bleeding and coagulation. Dekho. So in bleeding and coagulation, the basic question is, first of all, when the platelet adheres, it adheres by VWF and GP1B9 and the aggregation is by GP2B3. So once there is absence of VWF, we call them von Willebrand disease. And if it is GP1B9 absent, it is Bernard-Solis syndrome. Remember, B for Bernard, B for bada platelets, big platelets. And GP2B3A is referred to as Glanzmann thrombasthenia. Glanzmann thrombasthenia. Okay. Now, 1 is Bernard, 2 is Glanzmann. It's very, very important. Remember that 1 is B, 2 is G, and no confusion. Now tell me, very good. V is vinblastine and D is dacarbazine. Now you're looking like my students. Perfect. बहुत अच्छा. All of you. That's a good answer. So because vincristine नहीं होता, it is actually vinblastine, and you should all remember this answer. It can be asked this year. Now I have a question for all of you here. Wonderfully you are answering it. अब मुझे बताओ, in all of these diseases, which of them will show you high APTT? That's the answer to all question to all of you. Fatafat. Chalo. Now we'll discuss about the defects in the primary plug defects. The primary plug defects are petechiae, purpura and ecchymosis. Okay? So when you get a question on this any of these defects, you get a history of petechiae, purpura and ecchymosis. Now, how to remember the coagulation cascade? I will tell you to remember the common pathway first, and common starts from 10. 10 ka half 5, 5 ka half 2 or 2 ka half 1. Simple like them. 10, 5, 2, 1. Ekdam simple. Extrinsic mein only 1, 7 and everything else in intrinsic. 12, 11, 9, 8 all intrinsic. So now how to diagnose this? First of all, when you expect increase in the APTT, long name long pathway. So APTT, long name long pathway, PT, small name small pathway. Okay, short name, short pathway, long name, long pathway is how to remember the PT and AB testing. Now, yes, you all have answered it correctly. VWD, because it is associated with factor 8. Bada, bahut badhiya. Very good. That's great. Perfect. Ab dekho. Now, what your sample you take? It's platelet poor plasma. Now, just come back here and tell me which of these factor will cause no bleeding. It's a MCQ to all of you. Fatafat, tell me the answer. All of you. So this is a APT and this is a PT. PT is a longer pathway. PT is a short name, short pathway. Means extrinsic plus common pathway in the PT and intrinsic plus common pathway in the APTT. So what you add in APTT is kaolin. What you add in PT is thromboplastin. So if a patient has increased amount of PT and has a normal APTT, in that case the patient has factor 7 deficiency, factor vitamin K deficiency, 2, 7, 9 and 10 can also be deficient. Okay. Acha, why it is so? Because vitamin K causes gamma carboxylation glutamic acid and the same can be inhibited by an oral anticoagulant called as warfarin. Warfarin basically is PT INR, where you see the PT of the patient divided with the PT of the control and raised to the power ISI. Case 2 mein, if a patient has increase of APDT, normal PT, it means what? Yes, intrinsic pathway defect, and as you all answered correctly, it can be seen with von Willebrand disease, but can also be due to 12, 11, 9 and 8, but cannot be 10 because 10 is a common pathway factor. Okay, common pathway. Now, VWF causes addition and aggregation, but also stabilizes factor 8. And so it shows increase of APTT. I have one more question to all of you, and you tell me which test confirms VWD. All of you tell me which test confirms VWD. Waiting for your answers. Fatafat. Case 3, increase of PT, increase of APT is a common pathway defect. So 10, 5, 2 and 1 and can be seen also in DIC. 8 and 9 deficiencies, hemophilia A and B, both are X-linked recessive. But do remember guys, hemophilia C is factor 11 deficiency and parahemophilia is a factor 5 deficiency. This question can be asked, and these both are autosomal recessive disease. So factor 12 deficiency will cause no bleeding, and yes, ristocetin agglutination testing is used to confirm von Willebrand disease. Yes, very good. Von Willebrand disease. Okay, now VWD, 3 types: type 1, type 2, type 3. Type 1 is mild deficiency, type 2 is not a deficiency but a qualitative defect, and type 3 is severe deficiency of VWD. The most common among them is type 1. First and second is autosomal dominant, and the third one is autosomal recessive. Okay, how to treat these cases? Again, you can expect at least 2 questions from this topic, guys. That's a blood banking topic. Fatafat, all of you. So guys, all the PDF of this is shared already in Telegram group, and I am very hopeful that you all are actually liking this session. एक like तो बनता है, पहले मैं भी like मार देता हूँ किसको. अब तुम लोग भी एक like मारो, ढका ढक मारो, फिर आगे बढ़ते हैं. चलो. Now you come to the blood banking, a very important topic, guys. देखो, component, use, temperature and time. PRBC, correction of anemia, so at 2 to 6 degrees Celsius, and the time is 21, 35, 42 days depending upon on what thing you're storing it. For example, look at the below. If you are storing the blood in acid citrate dextrose, 21 days, citrate phosphate dextrose adenine, 35 days, and saline adenine glucose mannitol, we put it for 42 days. Okay, 42 days. चलो वापस आते हैं. So now FFP in DIC and FFP in DIC and in hemophilia A and B, -40 is the best temperature for 1 year. Cryo में होता है 8 VWF and fibrin. You just told me that factor 8 is stabilized by VWF, so you cannot separate them, right? And so they have to be together. Factor 8 के लिए hemophilia A, for VWF we use this in VWD. -80 for 1 year. So if you are preparing the cryoprecipitate, whatever is left out is cryo poor plasma. So whereas factor 8 is present in the cryoprecipitate, all other things minus VWF and factor 8 will be present in cryo poor plasma, and hence can be given in hemophilia B. This question was asked in this year's May INICET, guys. Notice this question may be asked again. Okay, -80 for 1 year. Platelet is for thrombocytopenia, for room temperature for 5 days. Washed RBC it helps to prevent the alloimmunization, especially in the case of the graft transplantation. Can be stored at same temperature but only for 1 day. ये याद रखना, this question is probable question this year. Okay, chalo. Massive blood transfusion. If you give a person equal blood volume as the patient's blood volume in 24 hours, or you give 50% blood volume in just 3 hours, it's called as massive blood transfusion. So when you give so much blood, the blood will be cold. तो क्या होगा? Hypothermia. RBC can lyse. तो क्या होगा? Hyperkalemia. Citrate can chelate calcium, magnesium. क्या होगा? Hypocalcemia, hypomagnesemia, and can lead to metabolic acidosis more than metabolic alkalosis, because you're giving only the RBCs, not the factors. It can lead to dilutional coagulopathy. And how to reduce this, guys? Give the ratio of PRBC, FFP, and cryo in a ratio of 1:1:1. That's a massive blood transfusion. Okay? So do remember, these are very, very important topics of the blood banking topic. Okay? Chalo. Now I move to the topic of general pathology. I hope you all are liking the sessions. Tell me, कोई doubt है तो फटाफट पूछो, all of you. Sir, is subtype 2 important, sir? हाँ, subtype is important because was asked in NEET PG. Else was not important, but since was asked in this year's NEET PG, subtype 2 का, अच्छा 2 का A, B, C and D, I don't think that's very important for you. मतलब just remember 1, 2 and 3, that's really sufficient. But yes, type 2 has A, B, C and D. And जहाँ पर 2 में एक नॉर्मैंडी टाइप होता है, नॉर्मल टाइप होता है, then there is a decrease amount of the electrophoretic pattern, but I don't think it's very important for you. इसको छोड़ सकते हो, ठीक है. Reversible cell injury. In the electron microscopy, cell size increases and look like a Mickey Mouse. देखो Mickey Mouse क्या होगा? Cell size increase. Why? Because of high sodium will imbibe the extra cell fluid. There is blebbing, there is organelle swelling, and there is pycnosis. In the same thing on light microscopy, they show what is called as a cell size increased, fatty change, chromatin condensed, and we use the word hydropic change. Now, this was a reversible injury. Now we move to irreversible injury. In irreversible injury, in necrosis, the electron microscopy shows two findings. Number one, calcium increases than magnesium, and calcium is called as large flocculent amorphous densities, whereas plasma membrane breaks to form myelin figures. These findings are seen in irreversible more than reversible injury. Irreversible more than irreversible injury. Now, in light microscopy, what happens because of the high calcium, which activates the lysosomal enzymes? ये question आएगा, this one, and it will activate the 4 enzymes: ATPase, protease, phospholipase, and endonuclease. So cell size will increase. There is protein damage, which stain will pink in color, and there will be karyolysis. Inflammation will be absent. Okay, so inflammation will be present in these cases. So now, along with a plasma membrane damage, protein damage, karyolysis, and inflammation, if the plasma membrane is maintained, we call the word coagulative. Not maintained, we use the word liquefactive necrosis. We use the word liquefactive necrosis. Okay, liquefactive necrosis. Okay, chalo. Now we move to the topic of apoptosis. What do you call them? Yes, programmed cell death. Okay, programmed cell death. इसमें क्या होता है? Intrinsic pathway में any injury sensed by, बोलो, BIM bid bad noxapuma. BIM bid bad noxapuma. And what happens? They increase the pro-apoptotic genes, decrease the anti-apoptotic genes. How to remember anti? Letter L. L say long life. So if a patient has a decrease in the anti genes, what comes out, sir? Cytochrome C. Combines with, sir, a PAF1. Forms what? Apoptosome. Activates what? Caspase. Caspase will cause protein breakdown and endonuclease activation. So this plasma will break down to form apoptotic body. What is the apoptotic body, sir? Condensed nucleus and a organelle, and removed by macrophages. What happens in extrinsic pathway, sir? Fast ligand called as TNF activates FAS. FAS क्या होता है? TNF receptor, which activates FAD, and FAD activates caspase 3 and 6. Ultimately will lead to the removal of the apoptotic body, and this pathway is referred to as efferocytosis. Very, very important. So what they can ask you is the difference of necrosis and apoptosis. मेरे तरफ से पक्का क्वेश्चन. ठीक है, देखो नेक्रोसिस में सेल साइज इंक्रीज, एप्रोसिस में श्रंकन, आउटलाइन डैमेज्ड इंटैक्ट, क्रोमैटिन लाइज्ड कंडेंस्ड, इन्फ्लेमेशन प्रेजेंट एब्सेंट, एंजाइम्स which enzyme? Lysosomal enzymes in necrosis and caspase in apoptosis. Next chapter, inflammation. Okay, inflammation. Ready all of you? Chalo. In the inflammation, the first thing to happen is this nucleus will move to the margins. The term is called as margination. Okay? Then rolling, then adhesion, then diapedesis, then chemotaxis, then phagocytosis, and then killing. All of you say with me: margination, rolling, adhesion, diapedesis, chemotaxis, phagocytosis, and killing. Killing occurs by two pathways. Number one, auxin dependent and auxin independent pathway. Okay? Now, the step for selectins is important. Selectins rolling के for rolling, selectins and CL levis. Remember, S for selectins, S for CL levis. For adhesion, ICAM, VCAM and integrins. CAM कैसे याद रहेगा? S for selectins, S for CL levis in R. तो R से S, rolling से S selectins होगा. And for adhesion, integrins and cell adhesion molecules. यार खुद सोचो, cell adhesion molecule cause adhesion. तो no confusion there. Integrins, beta 1 and beta 2 integrins. Then there is diapedesis. Then there is chemotaxis. And then there is phagocytosis. अब important question देखो. The topic of chemokine. Chemokine is C5a LTB4. कैसे याद रखना है? Chemokine attracting something. इधर आओ, सामने खड़े हो जाओ. So C5a आओ, खड़े हो जाओ. B4 stand before me. And IL-8 was asked in this year's NEET PG and bacteria as well. Now the examples of opsonin. C5a is a आओ chemotaxis. C5b, C4b, C3b. These are what, sir? Opsonin hai. With IgG, CRP and fibrinogen. Engulfment is held by Lys gene. If Lys is not happening, Chidiac Higashi syndrome. Remember, if LAD2, it is due to absence of cell levis, is Bombay phenotype, and LAD1 has delayed separation of umbilical stump. Next step is killing by auxin independent and auxin dependent pathway. Okay, now in auxin dependent pathway, what happens? The auxin is first taken inside and changed to superoxide. Then with SOD, it is changing to H2O2. H2O2 with the help of nitric oxide makes peroxynitrite, and H2O2 with the help of Fe2 plus makes Fe3 plus and a OH minus. Okay, so this OH minus is referred to as, this whole reaction is called as Fenton's reaction. An important topic and important question here is, among all other free radicals, the most potent free radical, all of you tell me in the group, what is the most potent free radical? Because the most efficient is hypochlorite, the most potent cannot be hypochlorite. However, H2O2 MPO halide is the most efficient bacterial cell system. If the question is iron, hypochlorite system, is H2O2 MPO and halide system. So my question was, what is the most potent free radical? And the answer is hydroxyl is the most potent free radical. Okay, most potent free radical. Chalo. Now, if a patient has absence of NADPH oxidase, the disease is due to absence of the FOX gene, and FOX gene absence will lead to a chronic granulomatous disease, CGD. Okay, CGD. My question to you all again here is, in CGD, which infection will increase? Your options are staph or strepto. My question is, in CGD, which infection is going to increase? Staph or strepto? That's a question to you. Okay, so most potent is hydroxyl. Yes, OH minus. चलो, about cytokines. Very important. Cytokines सर कैसे याद करें? बहुत easy. A for acute, acute से 1 और अल्फा याद हो जाएगा. acute से 1 और अल्फा. chronic से 1 to बीटा और गामा. 1 अल्फा acute, 1 to बीटा गामा chronic. इतना सिंपल है सर. वेरी गुड. स्टेफाइलोकोकस परफेक्टली आंसर. वेरी गुड ऑल ऑफ यू. ग्रेट. अच्छी तैयारी चल रही है. आई एम वेरी हैप्पी बिकॉज यू नो anyone who couldn't get a very good rank in the NEET PG and you are studying post NEET PG, you have a very, very good chance of cracking INICET. I'm telling you, just vouch for yourself. Take pride in what you have done till now and don't stop. Give the exam with maximum motivation and see how good it happens for you. And I am there for you at least. Okay? Chalo, let's move ahead. Chalo. This is again a probable question from the immune system. The various side types of IF pattern. If there is a complete green pattern, it's a homogeneous pattern seen in dsDNA antibody and the histone antibody. dsDNA antibody SLE, histone antibody in drug-induced SLE. Nuclear pattern, because nucleoli has what? RNA polymerase, and so the enzyme is diffuse SSC. Centromere pattern is seen in centromere antibody, and hence it is C for centromere, C for CREST syndrome, also called as limited SSC, whereas everything else is in speckled pattern. How to identify speckled pattern? Diffuse agar ban gaya granules, same diffuse if you're looking granular becomes speckled pattern. In nuclear you get 3 to 4 bigger dots. In centromere, how many centromeres you see? In a cell, there's 46 chromosome, and as you'll see 46 small dots. It's centromere pattern. Okay, and speckled pattern mein we get Smith antibody, that's a DNA antibody, SSA, SSB, Rho and La, SCL70 antibody, diffuse SSC, also called as topoisomerase antibody, and there is U1 RNP antibody seen in the mixed connective tissue disorder. Mixed connective tissue disorder is MCTD. Okay, done. Okay, next important question is upon the graft rejection. Hyperacute, acute and chronic. Occurs in minutes to hours, hyperacute. Within days and weeks, acute. After 6 months, chronic. Mechanism. Hyperacute is occurring due to a preformed antibody. That means antibody present beforehand the organ was given to recipient, whereas acute occurs because of post-transplant antibody or a post-transplant T cell mediated. Do remember one thing, guys, when it is T cell it will be type 4 hypersensitivity reaction as in seen in chronic and acute T cell, but antibody will always be type 2 hypersensitivity reaction. One more way to diagnose them is the biopsy finding. If you see organ में fibrosis and atrophy बन गया chronic. If you see organ में neutrophils, thrombotic occlusions and necrosis बन गया hyperacute. So neutrophils, thrombotic occlusions and necrosis is what? It is a hyperacute rejection. And in the antibody it is C4D deposition, and the T cells is CD3 positive T cells. CD3 positive T cells. So to solve the MCQs, how to solve it? If you get neutrophils, hyperacute. Fibrosis, chronic. None of them, acute. Acute में antibody, complement, T cell, CD3 positive T cells. CD3 positive T cells. Okay. So अब क्या क्वेश्चन है? सर प्लीज क्लिक न्यूक्लियर स्टेनिंग विथ इमेजेस. देखो इमेज का टाइम नहीं है, बट एक काम करते हैं. इफ यू आर देयर विथ मी राहिल टिल द लास्ट, आई विल शो यू दिस इमेज. पक्का डील? But you have to stay with me till the last. I'll show you that image, but you have to stay there. Okay, image-based sessions are starting on the Telegram group very soon from this week. All of you ensure that you are on the Telegram group and you keep on answering it there. Chalo. So now amyloid. Amyloid में first thing is amylase, and amylase word has been coming from starch. Okay, starch. Starch is localized or can be generalized. So localized can be seen in Alzheimer, A beta, Melry, carcinoma thyroid, A cal, insulinoma, AA, PP, and isolated atrial amyloidosis is ANP. Okay, ANP. ये क्वेश्चन तो आना ही आना है. amyloid. I'm telling you, amyloid से one question from my side. क्या रहेगा वो पता नहीं, but one question there from amyloid. In generalized, it can be AL multiple myeloma, primary, secondary में 2A, 1A primary, 2A secondary. In generalized, it can be familial and can be others. In the familial, it can be Mediterranean fever, which is serum amyloid, and cardiac, which is a mutated ATTR. Among others, senile amyloid. Senile है तो unmutated type of ATTR. ध्यान रखना. Familial mutation type, senile not mutation type, and there is dialysis associated, which is A beta 2M. Dialysis is A beta 2M. So again remember, Alzheimer A beta, MCT ACAL, insulinoma AAPP, isolated atrial ANP, primary single A, secondary double A, ATTR mutation familial, ATTR normal senile form, Mediterranean fever serum amyloid, and dialysis A beta 2M. Khatam, finish. Okay. Now most common organ kidney. Heart में it can show arrhythmias, and the most common cause of death is there. And spleen, it can lead to lardaceous spleen if it is red pulp, and sago spleen if it is a white pulp involvement. White pulp involvement. ठीक है? चलो. Now very important question. एक से एक important topic है यार. You cannot just go. अब तुम tell me any topic that you see till now is not important. I'm telling you, this session will give you at least 15 questions, 1.5 hours. ढंग से कर लो. Hematopoietic stem cells, common myeloid, common lymphoid precursor. If patient has absence of common lymphoid, pre-B, pre-T, pre-NK, everything is absent, and so it is what? Pro-B, pro-T, pro-NK, and hence it is neither B nor T nor NK. It is called a SCID, severe combined immunodeficiency. If pro-B is becoming pre-B, but pre-B is not becoming B lymphoblast, it's a BTK gene mutation. And BTK मतलब Bruton's tyrosine kinase. Bruton's tyrosine kinase. ठीक है? तो above SCID, then Bruton's. Below that, if there is a B cell formation but is unable to become plasma cells, it's a common variable immunodeficiency. Okay, common variable immunodeficiency. If a patient has been able to make B lymphocyte and is also making IgM, however, the isotype or class switching is absent because of CD40 deficiency, it is called as hyper IgM syndrome. Hyper IgM syndrome. And in the plasma cells making GADNE, if it's only absence of IgA, okay, it is selective IgA deficiency. Selective IgA deficiencies. याद होगा कैसे याद करेंगे देखो. At the top, SCID, then B, Bruton's, then C, CVID, then it is what? Hyper IgM, and below that it's selective IgA deficiency. Then, if patient has a Job syndrome, well, Job has a good fate, isn't it? Job karo, masti karo. So F is face, abscess, cold abscess due to Staph aureus, teeth, abnormal primary teeth, E say eczema and high amount of IgE. Fate, simple. Then catch 22 due to micro deletion of chromosome 22q. It is having two syndromes, DL syndrome and velocardiofacial defect. Whereas catch 22 full form, catch 22, C, cleft palate, A, anomalous face, T, thymus hyperplasia with decrease in T cells, C, cardiac defects, and H is hypocalcemia. Okay. Now look at the very important and very confusing also Behr lymphocyte syndrome is type 1 and type 2. What happens in Behr lymphocyte syndrome? The problem occurs in MHC, but because of MHC, T cells don't develop. For example, absence of MHC2, CD4 will not develop. Absence of MHC1, CD8 will not develop. That's what's called as Behr lymphocyte syndrome. Okay? Chalo. Next we move to the RBC anemia, but before that I'll look at some of the doubts that you have asked in the group. Pehla, sir, is type 3 hypersensitivity seen in chronic graft rejection? No. Chronic is due to basically type 2 and type 4. One thing you could have asked me is, sir, is type 3 seen in hyperacute? Yes. Hyperacute shows 2 more than 3 because those are antibody mediated, but it's 2 more than 3. PDF is already shared on the Telegram group. please go to my Telegram group by typing these words and you can download it from there. Very simple. Just put this on Telegram group. It is Dr. Praveen Ames, and you can just go get that. You can also go to my Instagram channel and you can get from my story. You can also take it from there also. Chalo, let's now move to the RBC anemia. Okay, देखो. So in RBC anemia, the first topic to discuss is hereditary spherocytosis. As you all know, autosomal dominant trait, the most common defect is ankyrin more than band 3 more than spectrin. And do remember, most common ankyrin hota hai, but the maximum hemolysis occurs in spectrin. Do remember, the only anemia where MCHC is increased is what? It is MCHC increased. It is what? It is hereditary spherocytosis. Okay? Now, if the patient has RBC membrane disintegration, then what happens? Surface area decreases, and so a biconcave RBC becomes spherocyte because the non-deformable nature and dehydration becomes a spherocyte and undergoes extravascular hemolysis. One of a recent diagnostic assay is called as EMA, whereas the old one is osmotic fragility testing, OFT. So my question to you here is, OFT mein, in OFT, where do you get, or what sample do you take in OFT? In which anticoagulant you take a sample of OFT? Tell me the answer. Okay, so this patient in EMA, because EMA binds to band 3, it can be used to confirm a case of hereditary spherocytosis. Treatment should be folic acid, blood transfusion, and if you remove spleen, the hemolysis will decrease, and so will the gallstone formation will also decrease. And now remember the typical graph: right shift spherocyte, left shift microcyte. Increased OFT, right shift spherocyte. Decreased OFT, left shift microcytes. Okay. Now we will discuss again a very important topic, and that is, okay, very good, heparin, perfectly answered. Heparin is used to take a sample for osmotic fragility testing. I'll surely discuss glomerulonephritis, but vasculitis is not today's discussion part. But yes, nephrotic syndrome, I'll discuss it surely. Pakka. Chalo, for those who have not put a like to this video, put a like. And one more thing, once the video is over, do ensure you put a small comment once the video is over. Not now. Abhi aage badhte hain. Just study now. In duodenum, Fe3 plus will change to Fe2 plus by an enzyme called as reductase. 2 plus is then taken by DMT1 and is then absorbed inside, stored in the form of ferritin. After getting absorbed, is taken by ferroportin. After getting absorbed, it is first changed to Fe3 plus by hepestin. Fe3 plus is taken by transferrin and then brought to the bone marrow macrophage. From the macrophage, it can be given to erythroblasts. Now, ferroportin has two roles, sir. Number one, it has a role for iron absorption from the base of the surface and also allows iron to come out onto the erythroblast. Ferroportin is under negative control of hepcidin. Okay, and do remember, inflammation can increase hepcidin, but inflammation can also increase ferritin. Recently asked question suno. Which protein helps to transport iron? Answer is transferrin. How is iron stored? Answer is by binding to ferritin. Third question, is excess iron harmful? Yes, because it produces free radicals by Fenton's reaction. Is बार का NEET PG question, this year's NEET PG question. Okay, now this iron being in the serum, we can call this serum iron, and the same iron is also called as a transferrin bound iron. The same iron is also referred to as a transferrin bound iron, this iron. Okay, now let's see the basic role. Just remember one thing, guys, and I want all of you to repeat with me at least 3 times. Ferritin when increase karega, transferrin will decrease. Transferrin determines total iron binding capacity. So high ferritin, low TIBC. All of you say with me: high ferritin, low TIBC. High ferritin, low TIBC. High ferritin, low TIBC. This is a rule which helps us to remember this table. What happens, guys, in iron deficiency anemia? What happens? in a case of iron deficiency anemia is, in case of iron deficiency anemia, since the serum iron low, ferritin is also low, transferrin saturation is also low. The moment I say low ferritin, TIBC is high. Okay, TIBC is high. Sideroblastic anemia में the arrows are exactly opposite, guys. The arrows, they're exactly opposite. ठीक है? That means in sideroblastic anemia, high iron, high ferritin, high saturation, and as a rule, high ferritin, low TIBC. What happens in ACD is that because of inflammation, ferritin increases. Because of high ferritin, TIBC decreases. One more thing that happens is because of the inflammation, hepcidin increases. So ferroportin decreases. Because of low ferroportin, serum iron decreases and transferrin saturation decreases. The whole table becomes simplified if you know the simple rule, and the rule says what? Rule says that ferritin and TIBC are exactly opposite. Ferritin and TIBC are exactly opposite things. Okay? Chalo. Now I move to some of the topics of systemic pathology, and the first chapter discussed here is lungs. So guys, is the audio clear from my side? I think it's clear from my side. Please, I can just confirm it. Okay, any doubts till now? Iron regulatory proteins क्या होता है? देखो, iron regulatory protein is IRP. So IRP, what it ensures is, pencil is not working. One second, huh? My pencil is not working right now. I think now it should be working. It's still not working. Just stay with me, okay? I'm just trying to get my pencil. I'm trying to cut my pencil, guys. This is not connected. Oh. Bluetooth is disconnected. Now everything is okay. Guys, I just want to connect my pencil. Sorry. Ready to mingle but single. Pencil is not working. We've got a small problem here, guys. अभी ठीक हो जाएगा. So, any doubts till now? I'll just try to also answer that as well, because this is creating some issue here. But from my side, the voice should be clear though. But I don't know why it's happening though. Um, for most of the students, it's okay. Audio is clear though. Yeah, chalo, done. Thank you for your patience. All connected. Right. So the question was asked to me कि sir कहाँ गया? Yeah, iron regulatory protein. So देखो iron regulatory protein is something like a protein like this, and the protein basic function is to bind to the IRE. Okay. So if this is IRP, this one is IRE. Okay. So what happens is when the IRP binds to the IRE, then the protein can't bind. The ribosomes are not able to bind, and so the amount of ferritin is low. Now the question is, when will the IRP bind to IRE? Only when the amount of iron is not sufficiently enough. So when the iron is less, so iron is unable to bind to this. When iron is unable to bind to this, then what happens? This one is free and is able to bind to this. That means, in simple word, whenever the iron is less, ferritin is less. Is actually happening because when the iron is less, the IRP binds to IRP and hence doesn't allow the ribosomes to bind to the mRNA. I made a video for this also. If you can just go to my Telegram group and in my YouTube channel, you'll find a video of the basic relationship between IRP and IRE. Okay, chalo, I'll move ahead. Now the next topic is about the lungs. So in the lungs, the first thing to see is the basic way of differentiating of a pulmonary disease, which is obstructive and restrictive. In the obstructive, the FEV1 by FVC, if less than 0.7, is obstructive. Obstructive can be of four types. It is emphysema, asthma, chronic bronchitis, and bronchiectasis. First question, which among them are reversible? The only reversible is asthma. Which among them can involve acinus? Emphysema involves acinus, whereas all of these others involves bronchus. अब देखो, centry acinar versus pan-acinar. First question they ask you. In the acinus, proximal acinus, centry acinar, proximal and distal, pan-acinar. Lungs, apex, centry acinar, base is pan-acinar emphysema. Etiology wise, smoking is the main etiology for centry acinar, whereas alpha 1 antitrypsin deficiency is the main etiology for pan-acinar emphysema. Now, in the asthma, the main finding seen is 3C. 3C क्या है? Charcot laden crystals. What are these? Eosinophil crushing artifacts. Then Crayola bodies, which are damaged respiratory cells, and Kirschmann spirals, which are impacted mucin plugs. In the bronchial biopsy, we see remodeling of bronchus. Chronic bronchitis is having a typical history of more than 3 months of productive cough in the last 2 consecutive years. Two things are asked here. Number one, increase of read index. Normally hota है less than 0.4, more than equal to 0.4 is highly suggestive of chronic bronchitis. And they can show you squamous metaplasia. Then is bronchiectasis, lower lobe showing you dilation and destruction due to important etiologies like cardinal syndrome, cystic fibrosis, Young syndrome, chronic infections, and autoimmune disease with foreign bodies. They can also lead to bronchiectasis. Okay, all of them written here. Next is the pneumoconiosis. Pneumoconiosis is the injury depends upon amount, duration, and smoking, and is inversely proportional to size. The three types of pneumoconiosis: coal worker, silicosis, and asbestosis. Among these three, first question, which of them has a more pathogenic variety. In silicosis, crystalline is causing more injury, and in asbestos, crocodilite causes more injury. Amphibole has little less injury but can also lead to more injury. But most common injury occurs due to crocodilite variety. The question they ask you is which variety is safer in asbestos? Answer is serpentine variety. Serpentine variety is also safer there. Now, in the lungs, upper lobe, and lower lobe is involved in asbestosis. Kaplan syndrome is seen in all these three, but the question asked is first seen in answer is coal worker pneumoconiosis. Risk of TB increased in silicosis, mainly involving a pleura is involved in asbestosis. Progressive massive fibrosis seen majorly in coal worker, but can be seen in other two also. Black lung pigmentation. This was anthracotic lung is a feature of coal worker pneumoconiosis, whereas the bilateral hilar lymph node showing you egg shell calcification is seen in silicosis. The only disease which can involve the pleura is asbestosis, can cause pleural plaques, pleural effusions, and can also show you lung fibrosis. Okay, they lead to asbestos body as well as ferruginous body. Now, can you tell me among these which has maximum risk of lung cancer? In these three, which has maximum risk of lung cancer? Tell me among these three. Okay. Next is lung cancer here. So yes, smoking, nickel, chromium, cadmium, and radon are the basic risk factors which can lead to lung cancer. Now, non-small cell cancer and neuroendocrine tumor. It's a pakka question for you in the INICET. Lung cancer, pakka. Okay. देखो non-small cell cancer में squamous cell cancer and adenocarcinoma. Squamous cell cancer most common in smokers. 2C hypercalcemia and cavitations. Microscopy shows keratin pulse and the typical IHC cytokeratin with P40 and P63. Adenocarcinoma seen mostly in non-smoker. India and worldwide this is the most common. Recent update क्या है? Most common lung cancer in India also nowadays is adenocarcinoma. Okay. Microscopically shows malignant glands with mucin production, and on the IHC shows napsin and TTF1. Okay. Napsin TTF1. This is a very frequently asked question. Among the neuroendocrine tumors, there is benign and malignant. In the benign, it's carcinoid causing nesting pattern, and in the malignant, it shows atypical carcinoid, small cell cancer as well as large cell cancer. Small cell cancer has most commonly paraneoplastic syndrome except hypercalcemia. It has a worse prognosis and almost virtually every case is seen in smokers. Okay. A typical morphology they show is spindle shaped tumor cells and can show you azopardy effect. The typical IHC of all these neuroendocrine tumors are synaptophysin, chromogranin, neuron specific analyase, CD56, and recently asked marker in May INICET was INSM1. Typical set for all of this net is bronchus, and they contain the hormone called as serotonin. If they come out into blood circulation, they can lead to three things: diarrhea, flushing, cyanosis, together called as carcinoid syndrome. Together called as carcinoid syndromes. Okay. Now, yes, very good. The most common lung cancer they cause is asbestosis. Perfectly answered. Very good. Next is the hepatitis. Again, one question which will surely be asked this year. For this, we'll discuss the structure of the virus. It is surface antigen, then inside it, envelope antigen, then the core antigen. And inside this is the DNA. So when the antigen breaks, the first thing to come out is surface, first, second, envelope, third, core. However, core being insoluble will not be coming out into blood. However, antibody is produced against the core antibody. So now look at this graph. The first thing to appear on the cell is surface antigen, then envelope antigen, then core antibody, and then again reverse, envelope antibody and surface antibody. तो sequence क्या है? Surface antigen, envelope antigen, core antibody, initially IgM and then IgG, then E antibody and then S antibody. Now look at the questions. Till the time S antigen is positive, the patient is infected. Once the S antigen is negative, now the patient has gone to recovery stage. In recovery, IgM shows recent recovery, IgG shows a remote or a old recovery. Now look at the questions. First question: marker for acute Hep B infection, SEC. If the question is first marker, HBs antigen. If the question is best marker, it is IgM. Recovery. In recovery, HBs antigen being negative with IgM positive, recent recovery, IgG positive, remote recovery. Core window. Core window matlab the patient right now is here. In this phase, S antigen negative, S antibody negative. This phase is called as core window period. Next part. Vaccination. In vaccination, the only marker should be S antibody and the marker level should be more than 10 milli international per ml. Mutation. If a patient has S antigen and S antibody both positive, we use the word surface mutation. Whereas if a patient has a E antigen negative, still has very high infectivity, we use the word pre-core mutation. In case of chronic infection, nothing is negative. S antigen positive, E antigen positive, IgG positive. Everything is positive. However, to differentiate chronic with carrier, in carrier, these should not be positive. If a patient has S antigen positive only without a symptom, then only you call the patient carrier state. It's a very important question asked in INICET on serology of hepatitis. Okay. So one question, how is INSM1 different from other markers? Because what happens is in these markers, whereas samtophysin, chromogranin, NSE, and 56, all of these often stain positive in cytoplasm. These often stain a cell positive in cytoplasm, like the brown color will come positive here as a. Okay. However, when we look at the 56 INSM1, they'll stain positive in nucleus. So INSM will stain positive in nucleus, and it's very strange. Why? Because these markers, the neural cells, they contain neurocirculatory granules, and granules are actually in cytoplasm. However, only one of them is nuclear marker. It's INSM1. Okay, is it clear? Chalo. Next, we move to the glomerulonephritis. Now, the first one is nephrotic syndrome. We'll then discuss nephrotic syndrome. In nephrotic syndrome, light microscopy. This is a very important topic, guys. Listen to me very carefully. If the patient has nephrotic syndrome, in the PSGN, it's a maximum endo-exocapillary proliferation in light microscopy. Electron microscopy, they show subepithelial humps. In the FM, they show starry sky appearance. Hump is a very important question. IgA nephropathy is also called as Berger disease, BERGER, Berger disease. The only thing to remember is IgA with mesangium. Solved. Question is solved. In case of MPGN, you see proliferation of GBM, mesangium, and capillary. When you see all the three things proliferating, in type 1, when the deposition occurs in subendothelial area, then what happens? Suppose there is a subendothelial area, this is a capillary. So between the main GBM, a new GBM proliferates. This is a new GBM, this green one. That's a new GBM proliferating. Because a new GBM proliferates, the name given is Strom tract appearance. Whereas in MPGN2, it's a intramembranous deposition causing dense deposit disease. Okay, dense deposit disease. In RPGN, in light microscopy, they show crescents. In gross morphology, shows flea, bitten kidney. Rupture of GBM in the electron microscopy, whereas type 1 shows linear finding, type 2 shows null finding, and type 3 shows no of the finding, but type 3 shows ANCA antibody. Do you remember? The 1 shows linear because they show only anti-GBM antibody. This shows GBM antibody. This shows antigen antibody deposition, and this one shows ANCA deposition. This shows ANCA deposition. That's a type 1, type 2, and type 3 deposition. Now we move to nephrotic syndrome. This is very, very simple. All nephrotic, they will always show you effacement of food process. Effacement. That's a rule. So if you see effacement without LM or EM finding, it's minimal change disease. If you see effacement with the subepithelial deposition, and because it's membranous, membrane will thicken. When they thicken, look at membrane. Once they thicken, they grow beside and around. When they go beside, we call them spike, and when they go around, we call them dome. The spike and dome appearance. Next is focal segmental glomerulosclerosis, FSGS. In FSGS, we see fibrosis in less than 50% involving the part of the glomerulus. However, in the EM, again same finding, effacement of food process, and the immune complex often deposits in the sclerosed part. Let's have a revision here. देखो, in the nephrotic syndrome, if patient has humps, क्या हो गया? PSGA. ठीक है, क्लियर हुआ? If patient has IgA deposition mesangium, क्या बन गया? IgA nephropathy. Tram track MPGN 1, dense deposit MPGN 2. If the patient has a history of kidney failure, in 4 to 6 weeks, think about crescents. RBGN. Crescents, light microscopy, fluid in kidney, gross morphology. Rupture of GBM, EM finding. 3 types of RPGN. One has antibody, which antibody? GBM antibody, so linear. 2 has antigen antibody, so granular. And 3 has the ANCA deposition. ANCA deposition. ठीक है? Then is nephrotic. Effacement, effacement, effacement. Simple. Effacement with no LM, no EM. Minimal change disease. Effacement with spike and dome, membranous. Effacement with fibrosis. It is FSGS. एकदम simple है ये तो. Okay. Apart from this, what I can ask you is the Alport syndrome. Alport syndrome shows the what finding? What does Alport syndrome show? Yes, basket weave appearance is Alport syndrome. ठीक है? RCC रह कुछ नहीं किया, मैं बता देता हूँ. RCC, most common RCC is clear cell cancer. Second most common, papillary cell carcinoma. Mutation of RCC in clear is VHL. In the papillary is MET mutation. Clear vacuoles of RCC contain clear vacuoles which is glycogen and lipids. Papillary is dark in color and hence called as also chromophilic variety, whereas chromophobic is having best prognosis and has a clear-cut halo around the nucleus. One more variety is Bellini and has a very poor prognosis. Bas, khatam. Now is the morphological change of MI. This is a very, very simple topic, guys, but is oftenly asked. In the heart, after MI, before 30 minutes, we see reversible injury finding and we'll show you what? Mickey Mouse image. We saw this before, right? Loss of microvilli, bleb formation, organelle swelling, pectinosis, all those findings. After half an hour, irreversible injury, which is what? Again, we read this today only. Calcium and marine figures. Then comes rule of pathology. Day 1, neutrophils appear. Day 3, become brisk. 3 to 7, macrophage. 7 to 14, glycogen tissue. Post 14, collagen. That means sequentially, what's happening? Sequentially, day 1, neutrophils appear. Day 3, brisk. 3 to 7, macrophage. 7 to 14, glycogen tissue. Post 14, collagen. Bas khatam. Kaise bologe? Say with me. Neutrophils, macrophage, glycogen tissue, collagen. Day 1, appear neutrophils. Day 3, brisk neutrophils. 3 to 7, macrophage. 7 to 14, glycogen tissue. Post 14, collagen. So if you forget this, then remember trick. TION is TEN, day 10. The mean of 7 to 14 is day 10. अब वो भी नहीं भूलोगे. Suppose the whole thing becomes confusing. कि सर 7 में क्या था, 10 में क्या था, 3 में क्या था, छोड़ो सब. 10 is glycogen tissue. So before glycogen tissue, macrophage. Before that, neutrophils. After that, collagen. Finish. There is CNS tumors. In the tumors, it is WHO grading of grade 1 to 4. 1 is benign and grade 4 is most malignant. How to remember all brain tumors? Sir, बड़ा कम जाता है, कोई क्वेश्चन नहीं है. Gliomas. IHC is GFAP. Gliomas can be astrocytoma, oligodendroglioma, and ependymoma. Ependymoma and oligo, they both are grade 2 tumors. Oligo shows fried egg appearance. They are seen in frontal lobe. Ependymoma, rosettes, true and pseudo, they often are seen in ventricles and spinal canal. Astrocytoma is grade 1, 2, 3, and 4, whereas grade 1 is pilocytic, grade 4 is glioblastoma multiforme. Well, grade 1 is having a appearance in cerebellum, grade 4 is often seen in cerebrum. Do you remember? Pilocytic is biphasic in original fibers and is also cystic, whereas this one shows area of necrosis around which tumor cells spread out. We call them pseudo palisading. Okay, now in the other brain tumors like meningioma, it has OMA. OMA will not be malignant, so no grade 4, 1, 2, and 3 is present. They show typical whirling type of tumor cells with a calcium deposition called as samoma bodies. Samoma bodies. Okay, samoma bodies. In the medulloblastoma, it is grade 4 tumors. It is peanut. Site is cerebellum. Do you remember name क्या है? Medulloblastoma. दिखता क्या है? Cerebellum. Okay. In microscopy, they show Homer right pseudo rosettes. Homer right pseudo rosettes. Next is thyroid cancers. In thyroid cancers, there are 4 types of thyroid cancer: papillary, follicular, miliary, and plastic. Mutation. Most common papillary, BRAF. Most common miliary, RET. And plastic shows often P53 mutations. Now, how to remember the papillary? Papillary means it will show you papilla. देखो papilla बन गया. In the papilla, the nucleus is not hyperchromatic. In fact, nucleus has a clear white area inside this. The clear white area is called as orphan nuclei, also called as pseudo inclusions. You can see the cells even on FNAC or biopsy, and as both are diagnostic. In follicular, we have to prove follicles, and follicles should invade the capsule. Can you see invasion on FNAC? No, sir. And hence you have to do what? Biopsy. Miliary carcinoma. It has a RET mutation. RET, this gene comes from parafollicle C cells, which is neuroendocrine tumors. Microscopy shows A cal deposition. Okay, A cal deposition, and A is what? Amyloid. A is amyloid. Anaplastic is often seen as undifferentiated tumor. A small revision. देखो, most common tumor papillary. Second most common follicular. Best prognosis papillary. Okay, worst prognosis anaplastic. ठीक है. Now into microscopy. So first mutation first. BRAF papillary, P53 anaplastic, RET in miliary, and hence it forms a syndrome of MEN2A and MEN2B. MEN2A and MEN2B, it shows miliary carcinomas. Now, papillary shows papilla, and papilla has finger-like projections. These papilla have orphan nuclei, also called as pseudo-inclusions. Follicular will show invasion into capsule and is called as follicular carcinoma. Miliary shows parafollicular C cells and is showing you neuroendocrine tumors. Okay, neuroendocrine tumors. Okay. Then is anaplastic. It shows a P53, which is undifferentiated tumors. Okay. Now, few important things you should know is a thyroid cancer. The main risk factor is what? It's a radiation exposure, which is PTC more than FTC. And lastly, they can ask you MNG. Goiter causes what? It causes FTC more than PTC. That's as simple as that. Okay. Ovarian tumors, biggest headache. How to remember all ovarian tumors? Dekho. As a rule, what happens? This is a ovary. This is a Graafian follicle. In Graafian follicle, there is a germ cell. Okay. This is a Graafian follicle which has granular cells. And this pink one is the granular cells. The outer blue one is theca cells. Some cell between them are Sertoli and Leydig. Now, the tumor which can arise from this capsule or the epithelium is called as coelomic epithelial tumors or surface epithelial tumors. The tumor which can come from these cells are called as sex cord stromal tumors. The tumor which can come from germ cell is called as germ cell tumors, and the tumor which can metastasize here is called as Krukenberg's tumor. Let's take it one by one. First one, what happens is coelomic epithelium is highly pluripotent cell and hence can change to multiple other cells, like they can change to fallopian tube. Fallopian tube has what? Ciliated column epithelium and hence the name is serous tumor. They can also transform to goblet cells of GIT, and what do goblet cells make? Mucin, and hence the name mucinous tumor. They can change to bladder, Brennan's tumor, and hence can lead to a transient tumor or a Brennan's tumor. They can change to endometrial glands, and hence the name is endometrioid tumors. And they can change to clear cells, and hence the name clear cell tumor. The five tumors of surface epithelium, and all of them have same tumor marker CA125. The problem of this tumor is these tumor occur usually in the post-menopausal phase with very vague symptoms. Because they have vague symptoms, they are often present in the grade 3, with the stage 3 and 4, and hence they have poor prognosis. The question they can ask you, number one, is serous tumor shows psammoma bodies. Mucinous shows pseudomyxoma peritoni. Wall third cell nests are seen in Brenner's tumors. Next, germ cell tumor, Delhi city, dysgeminoma, choriocarcinoma, immunocarcinoma, teratoma, and yolk sac tumors. Yolk sac tumor. Sir, dysgeminoma is almost same as seminoma. Okay, they have OCT3, OCT4, and NALOG G mutations, and they have this typical tumor marker PLAP, placental alkaline phosphatase, and LDH. Choriocarcinoma and adenocarcinoma shows beta HCG positivity. Teratoma is of three types. Benign is called as cystic or dermoid cyst. Malignant is second one, and sometimes they can make only one type of tissue called as struma ovary or monodermal specialized teratoma. Yolk sac tumor has a simple, remember this. Yolk of a egg becomes what? Fetus, and has the name alpha fetoprotein and also alpha 1 antitrypsin deficiency. Now the questions. Number one, teratoma. They show a typical protrusion called as Rokitansky protuberance. Yolk sac shows this typical cell in which you see vessels, and around the vessel you see the germ cells. This typical finding is called as Schiller dual bodies. Schiller dual bodies. Okay? So how to remember germ cell tumor? Delhi city. Delhi city. Next is the sex cord stromal tumors. Two of them make estrogens like granulosa and theca. Two of them make androgen like Sertoli and Leydig, and one of them doesn't make anything like fibromas. Fibromas often have Meek syndrome. Meek syndrome, guys, they have two things. One, ascites, and one is hydrothorax. Tell me, all of you, which tumor shows pseudo Meek syndrome? Name three tumors. I want all of you to tell me three tumors which can show you pseudo Meek syndrome. All of you message me here. Well, androgen secreting tumor are Sertoli, Leydig, and the hyalus cell tumor is the other name for Leydig cell tumor, and one can be combination of these two called as Sertoli Leydig cell tumor. What happens is this Leydig cell tumor, they often make testosterone which comes from androgens and cholesterol. When we see cholesterol deposition, we use the word Renki crystalloids. Remember, these two shows dicer mutation, very important for your INICET exam, very important, dicer mutations. Well, the granulosa cells, what they make, granulosa, they are the ones which make call Exner bodies. Call Exner bodies. Okay, is the inhibin. They make inhibin. Now, finally, they can be metastasis into the ovary, and the tumor is called as Krukenberg's tumor or the signet ring cell. Krukenberg tumor, or we can also call this signet ring cells. Signet ring cells. Okay, so let's have a small revision of this whole thing. Let's have a small revision of this entire thing. So I asked you which of these can show you pseudomyx syndrome. Yes, many of you are saying the right answer. The pseudomyx syndrome, it can be seen as you told me in the fibromas as well, and can be seen in Brenner's, and thecomas also can show you the pseudomyx syndrome, right? So let's have a small revision of all these tumors here. Number one, surface epithelial tumors. Tumor marker CA125. 5 of them. The name is serous, mucinous, serous, mucinous. It can be endometrioid, it can be Brenner's, and can be clear cell tumor. Among them, which show summer body, serous tumor. Which show wall third cell nest, it's Brenner's cell tumor. Next, the germ cell tumor, Delhi city, dysgerminoma, choriocarcinoma, adenocarcinoma, teratoma, yolk sac tumor. Which of them has PLAP LDH, dysgerminoma. Alpha fetoprotein, last one, yolk sac tumor. The choreo and adenocarcinoma shows beta HG production. Next, sex caused stromal tumors. Two of them make estrogens, granulosa and theca. Two of them make androgens, Sertoli and Leydig. Now, the tumor marker for granulosa tumor is inhibin because inhibin normally inhibits FSH. Okay, inhibin normally inhibits FSH. Now, in this, the typical microscopy finding is number one, if you see these type of follicles multiple times, we call them call external bodies seen in granulosa cell tumors. If you see the Ranke crystalloids, it is seen in the Leydig cell tumors. And if you see the Schiller dual bodies, we see this in the yolk sac tumor. Tell me, which among all the tumors is the most common ovarian tumors? Which is the most common ovarian tumors? The answer is yes, serous cell tumor. Which is the most common germ cell tumor? Answer yes, teratoma. Teratoma. Which tumor can occur in less than 1 year of age? Yes, answer is yolk sac tumor, also called as endodermal sinus tumor. Which of them can cause thyrotoxicosis? Yes, teratoma can cause thyrotoxicosis. Okay, these all are the questions which can be asked in this whole scenario. Finally, one question was asked to me, I'll show that image, the pattern of the IFA. So how to identify the different IFA? First of all, I want all of you to look at how to identify the IFA. Number one, if you see a green color entire area, completely green color area, it is referred to as a homogeneous pattern. The same pattern being seen as granules. However, the nucleoli is unstained. Unstained nuclei is called as speckled pattern. Speckled pattern. Homogeneous, same thing but granules without the nucleoli staining, it is called a speckled pattern. If you see only the nuclei staining, only nucleoli staining, it is called as nuclear pattern. And if you see 46 small dots, 46 small dots in a cell, it is called a centromere pattern. So as a revision, this pattern is seen in centromere antibody or CREST syndrome. Nuclear pattern is seen in RNA polymerase and hence it is diffuse SSC. Speckled pattern is the most common pattern seen in SSA, SSB. It can be seen in Smith antibody, U1RNT antibody and also the SCL70 antibody. And this pattern is seen in the SLE, is often seen in the dsDNA and also seen in the histone antibodies. Histone antibodies. If you want to have this telegram, if you want to have this PDF, go to my telegram group and just download it from there. It's already available. I've already uploaded this in telegram group. Go to the file section and you can easily download this PDF with the name of pattern of IFA. Just type this name, pattern of IFA. You can surely download it from my telegram groups. Any other doubts you have? Okay guys, if you have any other doubts, please tell me. Okay, this is the single way of revision of entire thing. I have shared the PDF already to you. It's better just go to this once more. It'll take just half an hour and this end of what you want to do in just 1.5 hours for revising the entire pathology there. I've given my best to give you the most concise way of writing all the notes myself and then giving it to you. So I have done my part of writing everything and giving to you in the notes form. What you should do is try to revise this for multiple times before the main exam. Try to revise this after revising the main notes and you're done with it. Once the video is over, please put your valuable comments and feedbacks and also message me on Telegram group and my own DM if you like the session. I'll be more than happy to answer queries there also. and wishing you all the best. In case of any difficulty, you can message me here. And okay, I'll just talk about how to prepare here. So what to talk from genetics made, I have a PDF with you, in which you can just go to the Telegram group, and you have to read the syndromes, especially Down syndrome, Turner syndrome, and Klinefelter syndrome, Edwards syndrome. These four syndrome you have to read. Marfan syndrome, again, that's very important. And not to forget, the pedigree analysis is very important. Usually in genetics, they don't ask you a lot of the important implications there, but they do ask you the non-Mendelian pattern of inheritance, especially the mitochondrial and imprinting is frequently asked in genetics. Okay. um, Gene androblastoma is that which makes the androgens, so we can just put it as androgen secreting tumors only. Okay. So what to do in last 20 days, I'll just ask you not to worry a lot. Dekho, the basic idea of getting a very good rank in any exam, especially in INICET NEET PG, is that you revise whatever you have read in the last few months. The basic reason of revising everything is that one time entire notes should go in front of you, so it becomes very easy to recall the stuffs in the main exam. So what you should do is focus on concising notes now. If you've read the notes before, it's the best time to concise notes, and these are the way you can concise notes. So what you should do is don't read anything extra. Try to concise whatever you read for the last few months. Please understand, revision comes from concising notes. Along with that, look at all the bookmark questions that you have put as a bookmark in or while preparing for the main exams. At least give 2 or 3 GTs from here onwards before NICT. Last 5 days may don't give a GT, but at least give 3 GTs till now, from now till 5 days before the main exams. Try to concise notes in the way I'm giving it to you, and please put maximum effort of reading right now. If you ask me number of hours, as much as you can. Even 14 hours will not be sufficient, because a lot of students, because of counseling not happening, they all are preparing. So get up guys, you have come a long way. I don't want any of you to stop. Please move ahead and let it happen. In case of any issue, please message me on Instagram or Telegram, and please put available in feedbacks also there. Wishing you all the best. I have tried to finish this entire thing in 1.5 hours, and also tried to take some of the doubts there. With this, I am just closing the session here, but will surely meet you again in days to come with plenty of those more things. One more important announcement, I am starting with the image based revision in my Telegram group. Do ensure you join it and also follow me there, and will also, in case of any issues, do message me in the same way. Guys, thanks a lot for valuable time. Take care, have a dinner, and then have a very good sleep also. See you all tomorrow. Goodbye.